Catherine Walsh today for this video interview. As you know, my name's Laura. I'm going to let Catherine introduce herself because I think she goes under several hats.
Okay, so thanks, Laura. So I'm Catherine Walsh, and currently I'm a professor of palliative care at Lancaster University with a specialty in obviously palliative care, working at the International Observatory on End of Life Care. I guess the other hat that I also have is I'm also editor-in-chief of the journal Palliative Medicine. So, and work a little bit more broadly in some elements of palliative care. And I guess just for context, Laura and I were just talking about this. I am a double Manchester graduate. I have a B nurse from Manchester University in the dark ages. I graduated in 1987, but I also did my PhD at Manchester University as well.
I think that's probably why, partly why at least, you've agreed to come back and talk to us, because you're incredibly busy. So I do want to thank you at the outset for giving your time freely to contribute to this learning resource. I'm really, really grateful. So we've got about 15 minutes or so, and we're going to talk about one of your very voluminous numbers of papers. And you've selected this for a number of reasons, which I think will become apparent as we talk about it. The link to the full paper will be available alongside the video, so do click on that. I was about to say if you want to read more, but I'll reword that as when you want to read more. So Catherine, an introduction to the study. Can you tell us a little bit about how you came up with the question in the first instance?
Yeah, so this is a study, as you'll see when you follow the link and as we talk, which is actually set in the midst of the COVID pandemic and was actually a collaborative response across a number of different universities to a funding call that came out from the MRC and the NIHR for studies appropriate to help us with our response to COVID. So it's a very contemporary issue. And we actually planned this alongside, as I say, a number of different colleagues as a mixed method study. So it had a number of different phases, which has included an international survey, a piece of work collecting very quantitative data on the response of individual patients to COVID-19 who are receiving palliative care, and the piece of work I'm going to be talking about today, which is a nested qualitative case study. So we had a range of questions that obviously fit with those different sorts of phases or prongs, if you like, of the study. But the question behind the qualitative case study work was much more about unpicking and understanding the experience of people providing care to those receiving specialist palliative care and who were often dying with and from COVID. So it was a much more exploratory, experiential question to try and understand what was happening on the ground for people providing care to people with COVID in the context of specialist palliative care.
So two things I'd like you to just expand on a little bit there. Nested and case study. Yep. Those words, both of those might be a little bit unfamiliar to students. So if you could just explain them in how they formed part of your design.
Okay, so the case studies were nested within the wider survey. So the survey went out very broadly, both across the UK and internationally, asking overarching questions about people's response to palliative care, to COVID-19 in the context of palliative care. We then analysed that survey and took the participants in the qualitative case study from some of the respondents to that survey. So A, they had to give us permission to say that they were interested in doing that. And we only worked with people in the UK, in fact, England, in this particular instance. But we also very carefully chose them to try and be representative in a way that is not, I don't talk about statistical representativeness, but of the range of organisations that were responding to us. So we chose organisations who were in different geographies, who were different sizes, that provided both adult and paediatric palliative care, that covered areas of different socioeconomic deprivation, that covered, we thought, we can't always know this, different sorts of populations. So we tried for some variability across the cases that we chose. So in that way, it was nested within, because it was about expanding and illuminating some of the questions that we got answers to in the survey, because surveys are great for looking across the board. We got hundreds and hundreds of responses to the survey. And for those that are really interested, all of that is published as well. So you can have a look at some of those other wider papers. But people, when they're answering a survey, even in free text, only give a snapshot of an issue. It was, in a sense, it gave us an overview of what was happening, but didn't give us that depth and detail. So we nested within that as part of drawing from the results from that survey, this case study. Now, case study research is a particular research strategy. It's very different to the way that we might use the word in clinical practice. So when I talk about a case study in clinical practice, I'm talking about you perhaps telling me about the care of Mr. Bloggs or Mrs. Singh and what their experience might be as a clinical case. That is not what we mean in this instance by a case study. A case study is quite a formal research strategy that takes as its founding element a case, and you as the researcher have to define the case. And that's really critically important. And you can define it in all sorts of different ways. In this instance, we defined the case as the palliative care being provided to people with COVID within a hospice organisation. So the hospice was, if you like, an organisational boundary, but that wasn't just the only definition of the case. It was about the palliative care being provided in the context of COVID. So the case definition is in the paper, but you'll see that. And we choose a case study when the interplay between the case that we're studying and the context within which it sits is very hard to differentiate. We know that there's a complex context around providing care to people with COVID or palliative care in the context of COVID, and we wanted to understand the interplay between the case and the context. Lots to read about if you are interested in case study research, but that's just a very high level summary, I suppose, of why we chose that as a research strategy.
Yeah, that makes sense. That's a really clear explanation. It sounds quite daunting because having obviously made good use of the survey to ensure that you've got that diversity represented in the demographic, that totally makes sense. Then having defined the boundaries of what constitutes the case, how did you then embark on what you were going to pay attention to and how you're going to kind of collect data within that context? So kind of what was the doing part, if you like?
So we planned a very pragmatic range of data collection opportunities, because one of the hallmarks of a case study is usually that you are collecting data from multiple stakeholders using multiple modes of data collection. Now, in reality, of course, we had to be slightly constrained because of the restrictions placed upon us because of the context of the COVID pandemic. So often in a case study, and in fact some of the case study work I've done previously, you'll see observation as a core element of that. That was going to be challenging in this situation. So we obviously recognised fairly early on that observation was not going to be possible. So the primary mode of data collection was interviews with a range of different stakeholders, which were all conducted online, like we're talking today. They were conducted via Teams or Zoom. We didn't see anyone in person, which was quite common during that particular wave of the COVID pandemic. But we also did some documentary analysis as well. We asked them to provide us with any particular policies or procedures. We looked at their websites. We looked at some of their outwardly facing information about how they were managing and dealing with COVID as part of that data collection process. In terms of the interviews, we had a very high level topic guide. So the researchers working alongside me who conducted most of the interviews wouldn't have gone in with a set load of questions. We asked a very broad opening question, which often, and I'm sure you can understand this in the context of COVID, led to a lot of information, which then as a researcher, you have to be quite careful about in terms of how you then pick up where your questioning are going next. So whilst we had a list of topics, we wanted to talk about some of the clinical context, we wanted to talk about the impact on staff, we wanted to talk about how we thought it affected patients and their family and other carers. Much of it is very iterative, it's very responsive. You just talk to me about X. Can we explore that a little bit more? Tell me how that felt. Tell me a little bit more about that. So a very opening, iterative style of questioning, rather than as you had with a survey where we had very fixed questions that everyone was answering at the same time.
I presume that part of that decision was because you're presupposing what they might answer if you restrict it too much, whereas this openness allowed for
Yes.
a bit more exploration.
And at the time where we were planning it and obviously putting in our application for research ethics approval and all the other sort of, governance and bureaucracy that's associated with research, at the time, we really didn't know the answers to those questions. Whilst there is some more evidence coming out now and some other similar studies, at the time, we wrote the application to do this in April 2020, right at the beginning of the pandemic. So we had to be very open and flexible because we truly didn't know what we were going to find. One can imagine theoretically and from looking at literature from other pandemics, that have happened or epidemics in the past, the sorts of issues, which is why we had some of those ideas for topics, but it had to be very open because of the nature of what we were studying.
Yeah, it was a very unique situation in a lot of ways, wasn't it? So whilst I would really love to hear about kind of how you proceeded with analysis, we probably won't have time in this discussion because I'm mostly really fascinated to hear what your findings were. As somebody who's worked in COVID and in specialist palliative care, I just would really like you to share those findings with us.
I think the only thing I would say about analysis, just very briefly, is actually how challenging it is to make sense of such a rich, diverse data set. These were quite lengthy interviews. We were very humbled that people gave their time from a range of different perspectives. So whilst for a range of reasons, some very practical, we didn't interview patients or family carers, we interviewed healthcare assistants, we interviewed nurses at various levels, we interviewed doctors, we interviewed chief executives, we interviewed finance officers. I mean, that's what I mean by the whole range of stakeholders. So you're bringing in lots of different perspectives. And the core thing in terms of the analysis is actually trying to understand some of the fundamentals of the phenomena that you're seeing. And as we immersed ourselves in the data, and there were a number of us involved in doing the analysis, it wasn't me, it was a range of people, what became increasingly apparent was the central concept of moral distress. Now, moral distress is a well-known phenomena. It's not something that we, came up with, but it was something that we were identifying within the data. And then we were able to look both at the definitions, theories, and other research associated with moral distress and look and interrogate some of our data, perhaps then through that lens as well. So if you like, there's a very inductive immersion in the data, seeing what's there, being open to the possibilities, but then the identification of something that we labeled, I suppose, and then interrogated the data for that. And I think what was very apparent from the findings was the acute ongoing moral distress that these people were finding, bearing in mind that by the time we got to these qualitative case studies, we were in the second wave of the pandemic. We'd already been through one wave, and it was there was a real sense of, oh no, not again, at the time that we were collecting those data, which as subsequent waves have continued, I'm sure some of our findings have only been exacerbated, I suppose. But we expected that people that we were interviewing were used to caring for people who were dying. They worked in hospices, they worked in specialist palliative care. This is their bread and butter. And in some senses, that was not the cause of the moral distress. The cause of the moral distress was that their moral values to provide care in a very particular way were not being enabled. So the infection control procedures, which everyone understood why they were in place, there was no, particular criticism of those, but having to work in a particular way, not allowing at that point in visitors to come in, working behind PPE all the time, the constraints of how the workload was managed. That was what caused the moral distress. It wasn't the death per se, although clearly all deaths are distressing and we have to acknowledge that for those of us who work in palliative care. It was that extra layer that really was in conflict with their values. And the values of people who work in specialist palliative care and hospice care is of attentive, responsive, holistic care. And they weren't able to do that. And that was a real challenge. And so that was the core of what we found.
Can I just ask a sort of follow-up question about that? You sort of mentioned a huge range of stakeholders there. Did you find that at those other levels, those kind of strategic and managerial levels, that was also a theme that was apparent? And did it kind of relate to values at those levels as well?
Yes, because I think, the people who work in those organisations have a sense of shared value. Now, what was interesting, perhaps from some of those more sort of strategic or organisational participants, was actually, and what mitigated some of this moral distress, was that actually suddenly the hospice sector felt incredibly valued. They felt part of a bigger system. The whole adrenaline fight or flight, being part of the NHS, getting some additional funding from, the NHS routes to be part of a system-wide pandemic response. Hopefully, I'm not sure they all felt quite the systems were joined up, but anyway, would actually really enhance their sense of worth and value. But also, the organisations are not huge organisations mostly. They're perhaps 1 or 2 inpatient wards if we're talking about inpatient care. And so these were people that were very close to those who were providing clinical care and could see and respond to the distress that they were seeing on a day-to-day basis. So not remote, somewhere even in another building on a big hospital site, but often in an office right next door to the ward, seeing this as a lived experience on a day-to-day basis.
Yeah, that makes sense. So clearly you didn't undertake this research to write a paper. You undertook this research because you wanted something to shift, you wanted something to change. So I wondered if you could talk a little bit to that now about kind of how your findings can actually impact either on our own insight into our own practice as clinicians, or into what we need to know about services and moving forward with learning from the pandemic.
And in fact, most of that conversation and dissemination took place well before we finished writing the paper and the paper came out. So as an example, there were Hospice UK echo calls that were happening monthly that we went to on many different occasions to present and update and get feedback from. And we did a policy round table and a stakeholder round table as dissemination events. So I think that's critically important as a researcher and as a clinician researcher. It's not just writing the paper, putting it out there and hoping that people read it. It's actually engaging with people on the ground to see how you can make that difference. What was really important at the beginning was actually just that validation of how people felt, a sense of actually it's not just me, and a real sense that they wanted this message to go out very broadly, which is part of why we did a stakeholder consultation, talking to people really quite senior within some of the NHS and hospice hierarchies, because actually just that sense of validation, and this is actually how people are feeling, was actually incredibly important. But I think the other message that was very important to people was actually about how we mitigate and manage this moral distress, and a very strong message that this, whilst there may well be some individual things that people can do, this isn't about an individual sense of resilience or well-being promotion. This is actually about an organisational and to some extent financial, because staffing is a real issue, response to moral distress. And that was actually really important in terms of trying to make a difference. But there were also small things as well. So as a little minute example, lots of hospices had put in place sort of wobble rooms, for people to go and have a rant and, have a chocolate biscuit or whatever. Now, that was only available to the people who were actually in the building. you know, if you're a community member of staff and you're out and about, you were actively discouraged from coming in the building because of the infection control protocols. And what we heard from people is that they were just in tears in the car and not able necessarily, in all instances, to access some of the support that was available to people who were actually within the building, because they'd actively encouraged people, for very good reasons, to be not in the building. So there was some real learning that was taken on board, I hope. Certainly people were talking about how to take that on board fairly rapidly in terms of how we support not just community members of staff driving around, you know, in their car, but also those people who were completely working remotely, but still necessarily, you know, providing telephone or remote support potentially to patients and being in contact with them in that way, and how we support all of those people providing care. So there were some very immediate things that people said they were taking on board. Now, as a researcher, that circle is not always finished. You know, I don't know necessarily always what people put into place. I just know the conversations that we had and the recognition that perhaps some things needed to shift as a result of some of those things that we found.
Wow. So the impact is not, I mean, it's kind of, it's really valuable, I think, for a study to bring back up important issues like moral distress so that they stay on the radar for us as clinicians working in normal times as well as unusual times. But all of those different ways in which you disseminated it, from informal conversations to kind of professional sort of specialist palliative care, yeah, it's really important to think about that in terms of research impact. When we do read a paper, it's so important to look at one of the obstacles to actually bringing about change, as being researchers do a study and then they let it sit there. So I think yours is a really really brilliant example of not only research that was actually designed and undertaken really rapidly, that is disseminated. I mean, when did you say you applied? 2 years ago?
Yes, it would have been March, April 2020.
It's just incredible. So,
and I think, you know, we've probably got, I don't know, I haven't counted, 10 papers that are out from the various different, and more that are still under review. And again, if you look at some of the resources online that we've produced, I think some of the policy briefings might be online, I'm not 100% sure, but there was that layer. There was the attending, you know, Project Echo, there were policy briefings, there were stakeholder briefings, there were you know, presentations at academic conferences, there were presentations at professional conferences, there were talking to individual organizations, there was the, you know, the layer of the academic, if you like, publications which are written in a particular style and manner. So, and I think understanding that as a researcher and how you reach out to people, a lot of activity on social media. We were, you know, we were trying to put things out. So layer upon layers. And as a researcher, you never quite know how something's going to fall, what impact it's going to have. And I think that's the challenge as I moved from clinician, which I was, to researcher, which is and now am. You move from an immediate gratification, well, hopefully gratification. Catherine, Laura, you know, thank you for being such a wonderful clinician, to an impact which you hope is perhaps sometimes bigger across a wider policy arena, but which you don't see that initial gratification. In fact, as I would say, tongue-in-cheek, as a researcher, most of what you get is a no. No, you can't have the money. No, you can't be published. No, you can't do this. So it's a very different way of being as a nurse, but actually one in which I think I bring my nursing background and my nursing skills and that understanding in a reflexive way to the way that I act as a researcher, not just in terms of the questions we ask, the research that we do, but how we disseminate that and shape that in policy terms.
Yeah, it sounds like people are at the centre of all stages, from thinking about it to designing it to then those conversations. So it's really clear to see from your description how your own skills as a nurse are brought into that. And I think that's why I'm really interested in showcasing nursing research, because very often we don't see it all in one place. We see nurses as part of teams, but I'm really curious about that very unique attribute that nurses can bring.
Yeah,
So,
and I'm also very clear, you know, it was a very multidisciplinary team. You know, it wasn't a nursing team, but there were nurses on the team.
Nurses on the team, and not nurses as research nurses, but nurses as thinkers and as designers and as, yeah, and I think that's kind of sometimes something that doesn't get so much of a light shone on it. But yeah, of course, kind of within teams and each of us learning from each other's particular strategies. I know for sure that the most learning I ever did as part of a team was one with palliative care consultant, an archaeologist, a sociologist and a psychologist all on one team. So definitely gives it a richness. But I think as nurses we often kind of, we're not so vocal about what it is that we do. So time has absolutely flown. We've covered most of the things that I wanted to talk about. Was there anything that you wanted to add? As I said before, there'll be a link for people to have a look at the full paper, but was there anything else that you wanted to talk about before we draw it to a close?
No, I think it's just an emphasis for me that my nursing research journey started as an undergraduate nurse, and it started as an undergraduate nurse at Manchester with an emphasis on evidence-based practice and using evidence to, where possible, underpin the decisions that we made as a nurse. Now, that's not always possible. We know the evidence base isn't always there, but it was that underpinning understanding which I think took me through my initial clinical career into doing a master's in nursing research, ultimately a PhD, and where I am now. So I think don't underestimate the possibilities of research as a career, and as a career at all sorts of different stages and levels within your career as a nurse. It's always been, you know, one of the pillars upon which I have formed my career, and I'm very grateful for that opportunity.
Random question, did you love it straight away, or did you need to learn gradually as a process about how research and practice were actually connected? Because I think a lot of our students kind of see it as a bit of a separate thing that they have to do, and then for some of them there's a real kind of light bulb moment, and for others
I'm afraid I'm a bit of, or always have been, a research nerd. So if our lecturers, you know, back, as I say, in the dark ages, had said, oh, you know, there's a new paper out on X, I would be the one that was in the library finding that paper, photocopying it. We didn't have them electronically in those days. So I think for me, there was always that sense of excitement and interest, and how can I put this into practice? But as I say, I worked in the NHS for, I don't know, 15, 20 years before I did my PhD. You know, this is a long range journey for me.
Yeah,
so I think, you know, it's important to say I didn't then just go straight into research. I had a long and very varied clinical career with lots of different jobs and roles before I eventually bit the bullet and came to do a PhD and then became a full-time researcher.
Wonderful. So self-identifying as a research nerd, Professor Catherine Walshe. I would really love to thank you again for your time. Very, very grateful for your insights and your inspiration. Thank you so much.
You're welcome.
Stop the recording now. Try and stop the recording. Stop recording. Okay, that should have stopped now. Has it stopped? I'm going to need to blooming edit it now, aren't I? Got a very laggy computer. I hope the sound of the fan didn't.
I couldn't particularly hear a fan, so
yeah. Stop recording.